You're live, Jonathan.
Thank you. Good afternoon, everyone, and thank you for joining us for the third of our integrated care system workshops. I'm Jonathan Fellows. I'm the chair designate of the Integrated Care Board, and I'm joined again by Mark Axel, who is the interim chief executive officer of the Integrated Care Board. We're recording this session, as we've done with the others, for colleagues that can't be with us today, so they'll be able to watch it later. And if you have any questions, then please put them in the Q&A box. We'll answer as many as we possibly can at the end of the session, but any we don't get to, we'll put the answers onto the website. So, to recap, I'll run through sort of the previous elements of the two workshops we've held already, and then hand over to Mark to take you through some of the governance and other issues. So on the recap, very briefly, the Health and Care Bill got royal assent on the 28th of April, which means we'll definitely become an integrated care system with an integrated care board on the 1st of July. The main thrust of the Health and Care Bill is to build on the collaboration and the working together that happened across all systems during the COVID pandemic, and to improve health and care. And later on, we'll see why that's so important for the Black Country in particular. And our ICS really has two parts. One is the Integrated Care Board, which will be focused really on improving NHS services, providing care in communities where possible and only where necessary in hospital. And then the Integrated Care Partnership, where we'll work with a range of partners, including our local councils, our voluntary organisations, the police, the fire service, universities, colleges and large employers, to look to improve people's lives and to deal with the inequalities that currently exist across not just health and care, but more widely. So some of the health challenges that we face, again, later on we'll talk more about some of the specific ones in the Black Country, where compared to the rest of England, people don't live as long. They don't live in as good health. They live in much poorer health. They're living often with long-term illnesses like diabetes or coping with cancer or heart disease. So there are a lot of challenges in health, and specifically in the Black Country. And our purposes as an ICS, broadly, there are four of them, but broadly the two on the left are the areas that the Integrated Care Board will focus most on from an NHS perspective: improving health and healthcare and outcomes, and making the best possible use of the money that we spend. While the two on the right will be the focus for the Integrated Care Partnership, the wider partnership, how we can together deal with inequalities and how we make the Black Country a more thriving place for people to live and work in. And there are also four different P's that Sajid Javid, the Health Secretary, recently set out for systems to focus on, and those are prevention, personalisation, performance and people. It's very much two sides of the same coin. They fit quite well with those purposes that were set out before. So that's a very quick recap of where we got to on the first two workshops, and I'll hand over to Mark now.
Yeah, thank you, Jonathan, and welcome everybody that's watching online. So those of you who attended the last session, as we go through the session, we will ask you a question, and this is an opportunity for you to give your feedback. So this is in addition to any questions you want to ask us as well. So the first question we want to ask you, and please use the chat function to give your thoughts and views, is what do you think are the biggest opportunities that you see, no matter what your role or your interest and why you're here today, for working together as a system? And if you put one at the start of your comment and then put your comment in the chat, we'll give you 2 minutes and then we'll go through some of the comments that we've received. So based on your interest in today, what are the biggest opportunities that you think that are there for working together as a system? And we'll just give you a couple of minutes just to get those thoughts down and then we'll go through them. Okay, I can see some really fantastic comments coming in already. Thank you, and there's still more coming in. Thank you for all of your comments. Better and more efficient patient care. Absolutely, the whole aim of this is to join up health and care in a way that I think our public expect us to do, and that we share learning, we share best practice, and we strive for the very best outcomes. Yeah, better quality and care for the population, preventing hospital admissions, keeping people well in the community, focusing on those wider determinants of health to prevent poor health. But when people do need support, that where possible we do that in the community. Real integration, but that means losing the labels of secondary or primary care and really joining up services together. Entirely agree with that. Organisational boundaries should not prevent good care happening. It should be seamless. The patient should tell their story once as they go on that journey. A kind of common goal, and the public see and hear us working as one. Thank you. More equity across the system with investment for primary care and community services. More joined up communication and thinking. Sharing best practice to improve care and reduce unwanted variation. When we look across the Black Country, we can see that different parts of our system, our different places, are all doing something that if we learned from each other would make really the right ingredients for outstanding care. So it's really important, I agree, that we improve care and we challenge each other on variation. If you look at some of the health inequality indicators, there's a 10% difference just by travelling from one borough of the Black Country to the other. Just picking up some of the other comments, and we will pull all these together. Lots of comments about communication and collaborating, person-centred care, less silo working, more benchmarking, which is again about setting those standards in that care, doing things once across the system and not 4 times. I think for some things that's right. We absolutely want to bring the standard and quality of care right up to the very highest it can be about the Black Country. But what I'd say is that we also want services, when it's appropriate, to be nuanced for the community they serve. So the needs of a population in Wolverhampton may be very different to the needs of a population in Sandwell, but our public should expect a level of service no matter where they go across the Black Country. and I'll pick out a few more. Yeah, something about economies of scale, value for money, balanced at place to deliver, most certainly, and that I think is that piece around standardisation and duplication, where we can do things well at a Black Country level, and does present better value for money. We should absolutely be bold in using that money to invest in the prevention of gender and health inequalities. I agree. I'll just pick one or two more up. Maximum opportunity for specialised services that are not always possible on a place level, or even possibly services that we don't currently have in the Black Country because we have worked in 4 separate ways previously. So you know, I know from my background, when I merged the Mental Health Trust, for example, there were services that the 2 predecessor organisations had looked at very separately, the 2 populations that they represent. But when you start to think about one service for the Black Country, that really does start to work. And I'll just pick one more. Having a workforce that represents the population the ICS is serving, absolutely, and that will be a priority for all of us in the system. So thank you for all of those comments. We will capture them and we will find them incredibly helpful. So next slide, please. So I'm going to talk to you about integrated care, the ICB element of this, and how it will work and how it will be governed. Next slide, please. So through a process we've been going through over a few months now, we've been recruiting the board of the Black Country ICB. So how will the Black Country ICB be made up? Well, it builds very much on some of the comments that we've just seen in number 1 there about how do we work without organisational barriers. So the board of the Black Country has some designated roles, some roles that all systems have to have, some roles that we've actually decided are really important to us as a Black Country system, but also has partner members around the table. So no longer have you got a board deciding how they commission services and another deciding how they're provided. We want to bring the 2 together. So you've got Jonathan as chair, and I'll introduce some of the other members as well. The Chief Executive, Chief Nursing Officer, Chief Medical Officer, Chief Finance Officer, Chief People Officer, a Chief Equality and Innovation Officer, because we recognise that working with our partners, there is so much we can do if we give it the right profile around health inequalities. A number of non-execs who I'll introduce to you in a moment. Some partner members, so there'll be 2 places around the board table for both acute and mental health organisations. There'll be 2 places around the table for our local authorities, recognising the wider care agenda and the wider link to our communities that we need to create, and 2 partner members for primary medical services, so for GPs, to make sure that the voice of primary care is strong around that table. They are kind of the board member roles, but equally we'll also have wider participants as well. So other people may attend the ICB if we're focusing on a particular subject area. Our directors of public health, Health Watch, and the voluntary sector will be very much part of that participating group. So that gives you a feel for the board of the Black Country ICB. Next slide, please. Underneath that, we will create a structure that, for any of you that work in NHS organisations, you'll be very familiar with, and each of those committees will have a particular role for a particular priority that we have as we develop as an ICB. So some of those will be statutory that we must have, and those 2 are the audit committee. So they make sure and review independently everything that we do across our organisation and across our system. We have internal and external auditors that will advise that committee. They will make sure that our processes are robust, that we have policies and procedures in place. And of course, a big part of that is making sure that as we commit every Black Country pound to health and care, that we are accounting for and being held to account for how we spend that money. There will also be a remuneration committee, and that will be led by the non-executives only. And that will be to make sure that in setting remuneration for the ICB, that's fair and appropriate, and that recommendations are made in an independent way. There'll be two committees that focus on assurance. Firstly, even though we want to work in a different way, there will be a number of areas that we'll still have to commission. So we need to think longer term about how do we contract with the organisations that we need to, and start to think about long-term contracts, not just one-year contracts. So then enables us to plan for services better, but think more about what are the outcomes that we want to get for the population that we serve through those contracts. We still need to contract with our GP colleagues, and during the next couple of years, we'll take on the responsibility for dental, pharmacy and optometry, which is currently held regionally. So we'll need to make sure through that primary care work that we've got good, strong relationships and contracts with all of those services. And particularly important is how are we commissioning at the right population level, what we call place, or what you may know as the 4 areas of the Black Country, on that local commissioning basis. So how are we moving commissioning more locally to where it can make the most difference? And that ties very much into the involvement and engagement agenda, which I'll talk about at the moment. Moving that relationship around commissioning services to the right population level so that we get services that really are responsive to the communities that they represent. We'll have a system development committee that will oversee the development of our places. Some of our collaboratives that are forming, our acute trusts are increasingly working more closely together. The mental health and LD trust are taking on more responsibilities around providing those services. And I know primary care increasingly are looking at how they work at a Black Country level. And then, of course, there's the business of committees. So the business of finance, making sure we deploy our resources appropriately. The many indicators of performance across the Black Country, be that how long people are waiting for surgery, waiting times for access for primary care, waiting times for mental health services will sit under that performance agenda. And digital in terms of making sure that we continue to drive forward, have really strong and robust systems, but equally start to think about exactly what the digital agenda can bring to how we deliver care. A Quality and Safety Committee, which will absolutely keep oversight of everything we do to make sure that from a safety and a quality perspective, it's as it should be. And actually the People Committee, which is about making sure as a system we're developing our roles, our workforce to deliver for the future, that we've got roles that are attractive, that as an organisation we are seen to be developing our workforce that's representative of the population that we serve, as somebody said in the chat. And each of those will report directly into the Integrated Care Board. Next slide, please. So we've recruited our non-executive directors. You've met Jonathan already. Alan Edwards has joined us, who will take on our audit committee. So Alan's got a vast wealth of public sector experience. Some of you may recognise the name. He's previously been involved with Royal Wolverhampton Hospital, Walsall Healthcare. He's currently a non-exec at Birmingham Women's and Children's Hospital. He's on the University of Wolverhampton board and has also had connections with some of the big accountancy national bodies. So Alan will head up our audit committee. Dr. Sonia Ashraf, who's a GP in Birmingham, will take our lead from a non-exec perspective on ensuring that the executives are delivering on our quality and safety agenda. Ganjit Hunjan, who some of you all know, 30 years in the NHS, including time at Sandwell and West Birmingham Hospital. I think she's on boards of governors at some of the schools in Sandwell. So Ganjit will lead on the finance, performance and digital. Ranjit Sundhi, CBE, will lead on our people and remuneration agenda. And Ranjit's got a huge public body background in terms of roles. He's been on National Gallery, national committees, national groups recommending to government on different subjects. But he was also very involved with Sandwell CCG, so has that knowledge of the Black Country as well. And then from an inequality perspective, Bishop Llewellyn Graham, who has vast experience across the voluntary social care sector, housing sector, the not-for-profit sector. And the role of the non-execs is to hold us as execs to account on behalf of the public that we're doing things in the right way and that we're striving for the very best standards that we can. Next slide, please. And then we have our executive officers, which we're in the process of recruiting to. So I'm Mark Axel, I'm the Interim Chief Executive Officer Designate of the ICB. Some of us do hold these designate titles, and obviously it's designate because until the 1st of July the ICB doesn't actually form. Delighted to recruit Dr. Ananta Davi as Chief Medical Officer. Dr. Davi has joined us from Lincolnshire Partnership NHS Foundation Trust. She's a CAMS psychiatrist by background. Dr. Davi is from the Black Country, and some of you may know Dr. Davi from her work when she was previously at Dudley and Walsall Mental Health Trust. Our Chief Nursing Officer is Sally Roberts, who has worked in the Black Country and for the CCG for many years. Sally is well known to many of you, so brings that continuity as well as that clinical and quality experience. Tom Jackson will be joining us on the 1st of June, and Tom is the current Chief Finance Officer at Dudley Group. But prior to that, Tom has worked in commissioning, has worked a lot in some of the big cities on some of the healthy partnerships, which is absolutely what we're trying to achieve in the Black Country. And Matthew Hartland's our Chief Operating Officer, and Matthew is currently the Deputy Chief Executive for the CCG. We do have 2 more roles to fill. One is the Chief People Officer, and I'd hope that we'll make an announcement in the next few weeks on the appointment to that role, and the Chief Equality Officer, which we are just going through the process of reviewing that role to make sure that absolutely we get the right candidate to come in to what is such an important area. Next slide, please. So you've met the people. I've kind of given you a brief run through of what their responsibilities are and the areas we're thinking about focusing on. But your next question, again, we'll give it 2 minutes, is what are the most important areas, topics to you that need representing at that ICB board? What would you like to see the ICB board talking about? If you had an opportunity to come to the ICB board, which they will be in public from the 1st of July, so you absolutely can do that. What are the questions you'd like to ask the ICB or see us talking about? So again, 2 minutes. If you put 2 at the start of your response, we'd really welcome your comments. So 2 minutes to get your comments, and then we'll run through them again. Okay, thank you for all of your comments. I'll just run through them. Somebody's asked how much will this board cost with all these people enrolled? So just to be clear, this is not an addition to what we have in the Black Country. So the ICB will replace the current CCG or Clinical Commissioning Group and will assume those responsibilities and take on the current responsibilities that the CCG board takes on. In terms of exact cost, I don't have that to hand, but if people are worried that this is an additional level of organisation within the Black Country, it's actually replacing an existing organisation. In terms of what we should focus on, health inequalities, prevention agenda, workforce, digital and data strategy, population health and work around the Core 20. So the Core 20 is a national programme that wants some of the most deprived areas in the country to focus on what are the core outcomes that we need to improve for the population. And in the future, it may be that we do a future session like this that particularly focuses on that area. Suicide prevention, collaborative work across the system. Thank you, Matt. I'd agree with that. It was great to see walking into the office this morning the campaign that Wolverhampton have got going now, but I'd like to see that really joined up across the Black Country. What will Black Country Health look like in 2070? It will be a virtual world with the metaverse in full swing. How can we plan now to deliver healthcare in a virtual world? How many EBEs will be involved? Thank you for that comment. So EBEs are experts by experience, and we're absolutely planning to have EBEs involved, experts by experience, in how we develop services. And I'll come on to some of that in a moment about how we are going to develop that and the work that we've started already. And the recognition of the voluntary sector, the removement of barriers around integration, waiting times, absolutely recognise that as a challenge. The true integration of pharmacy, dentistry and optometry, as we bring those across over the next year or so, absolutely need to make sure we're mindful of that. Empowerment and making staff feel happy, thank you. Waiting lists, neurology, health inequalities, research, safeguarding, a hugely important topic. Lots on waiting lists, enabling people to get the care that they need. And I'm just picking up one or two final comments. Oncology and neurosciences, cancer outcomes, access. So thank you for all of those comments. We'll definitely pick those up. There's some themes there that we'll definitely share with the ICB board members as we go forward. Next slide, please. So our approach to working with people and communities. Next slide. So we've been doing a lot of work on this already, kind of representing a number of different organisations. We've developed our approach to working with people and communities across the Black Country. And the approach kind of sets an expectation or a set of standards, I guess, that the ICS and all of its partners should agree how to listen consistently and collectively, and most importantly, act on the experience and aspirations of local peoples and communities. We started this work back in November, which seems like a long time ago now, with virtual sessions. But we've also held some face-to-face sessions, and I was able to attend one of them, which was held at the Hawthorns in West Bromwich. And the aim has been to really develop with various different groups, with community reference groups, with different people from different parts of our community, a kind of way of building our system-wide approach that means something to them. This is not something that we're imposing on communities. It's about building it with them. And on the right hand side of that slide, you will see the kind of feedback that we got summarised up, and something that we absolutely mindful of and recognise as we move forward. So absolutely we want to be accountable to our people and our communities. So I've said to you, our board will be in public. Our place-based partnerships need to develop how they work as individual boards and start to move those into the public. But we need to also make sure that we're accountable, that when you've told us how things need to change, that we respond to that. We absolutely recognise that one size doesn't fit all. What works in Tetnall may not work in a particular part of Sandwell, for example, and this is not about pulling everything up to a Black Country level because we believe that's the right way forward. We know that a huge proportion of the impact that we can make on health and well-being people comes from their local communities and the wider determinants of health within those local communities. Some 70–80% it's suggested the impact that can be had. So a one size fit all approach just will not work. It starts with people and communities. We should show that we trust them and give them the opportunity to empower them to make that happen. And we know that through COVID, we've still got a lot of work to do for communities to truly trust public services and to make sure trust that their public services are going to be responsive to what they need. So working with the already trusted voices that are in those communities are key. So this is not about building something separate to the good work that goes on through the voluntary sector, through Health Watch and community groups. Every leader I've spoken to who works in the system wants to invest in people and communities, wants to create the headspace, the kind of financial headspace, headroom to be able to invest. And that will mean scaling some things up the right things to a Black Country level. But it's all about then how much can we invest on the prevention agenda in particular to support investment in people and communities. And it's really important that we go at the right pace and approach this in the right way, and we develop those relationships over time, that we listen if something's not working, that we sense and listen from the feedback you're giving us, and we change our approach if it's not the right way to go and the feedback we are getting is not delivering the outcomes that our public would expect, and we're not working in a way that gives our communities the belief that we want to make change with them. Next slide, please. So we want to be known as a system that's open, honest, equitable and inclusive, and that's both in the way we deliver health and care, how we support our staff and how we work with partners. So from beginning to end, we want to create shared decisions and actions and create the right environment for that to happen, that people can feel they've contributed, that they've been listened to, and they can see their part really in developing what we want to achieve at the right population level. And the question about experts by experience absolutely pays into this, because the best experience is lived experience, and we absolutely want to capture that in the way we develop it, both at a borough level, our 4 places, but also in how we develop as an ICB across the Black Country. And if we have that shared approach, it will help us to maximise what each of our organisations is doing in terms of how we engage and work with you. The comments at the start about how do we work seamlessly as a health and care system in a way that maybe you don't see our organisational boundaries anymore, that we're involving you in a consistent way, that we're delivering those services. If we get this approach right, the feedback and the changes that we'll make will hopefully start to move us into that place. And of course, there's a commitment that we use our collective voice, both in our communities, our neighbourhoods, if need be at a place level, Sandwell, Walsall, but equally we use our collective voice at a Black Country level where we think we can gain investment and create new opportunities for the population that we serve, and grow networks where they need that kind of level and that kind of voice to be able to challenge and champion what our communities think. Next slide, please. So combined with this approach, there's various mechanisms which will create that environment. We're shifting from individual organisation conversations to ones which put that community at the heart of it. And you'll see on the right hand side some of the ways we're doing that. So patient experience feedback, absolutely vital. We've already set up a Black Country Voices panel. We have the place-based citizens forums. We can have particular community conversations that can be geographical communities, but equally it could be a community around a particular condition or a particular area of focus that people have interest in. Doing lots of public engagement events. This is part of that, I guess. but doing more of that. This is a particular area that we want to cover. We've stuck to kind of virtual ways of doing that, and there is something about learning about that for the future, but equally going out into our communities and definitely using that trusted voice approach in terms of building that trust with our communities and demonstrating that we're serious about making changes as we go forward. Next slide, please. So next steps, well, we want to keep talking and listening to bring the approach to life. This is a step forward for all of us, and absolutely for our peoples and communities to see and feel our commitment. So Jonathan and I are absolutely committed to this. That's why we've been putting on these events as a start. But we want to set the right environment, set the right tone about empowering people around their health and care, that it's driven by your views. That good involvement is the responsibility of everyone, and make culture where that you feel that's genuine, that you can see that change happening based on your feedback, and that no matter what we do, and as some of the executives you met on the screen that'll be a key part of their priorities to make sure whether we're talking about the money, we're talking about a particular service, we're talking about quality and safety, or as we develop our wider determinants, be it about housing, or the impact that education can have on health, that we're involving you every step of the way using some of the tools that you can see there on the screen. Next slide, please. So based on your experiences, and we've got 177 of us on here today, question 3 or comment number 3, so put number 3 at the start of it, is what would be top of your list to help embed this approach within your organisation? Or I guess, what would be top of your list if we were to embed this approach across the system? So 3, and then what you think we need to do. What's top of that list that you need to see us doing to make this work? And again, we'll give it a couple of minutes for comments. And please remember to put 3 at the start of your comments so that we can make sure we pick them up as relevant to this particular area. So thank you for the comments that are coming in. I'll start to work through them just so we can share what's come through already. So keep talking and listening. Absolutely, we want to have that conversation, but the most important thing is we do listen and we do take action. Ensure this change belongs to and feels transparent and easy to understand for everyone, not those who just regularly engage with us already. Go to communities, not expect them to come to us. To do this, reorganise services and do it on an accurate and evidence-based approach. accessibility for all and reaching the community as a whole. All organisations work together in the interests of patients, not local profiteering and politics. Space to breathe and think. In order to lift our head into the ICS stream, we need to create a little space to look outside of our own workspaces and appreciate and contribute to the bigger picture. Be clear, open and transparent in communication. Involve the voluntary sector more with decision making. Communication again has come up. Cascade the values that we're aiming for across the workforce. Design the patient's journey, service integration with the patient's voice at heart. Understand the set of outcomes fully and know where changes are required and the cost of those services involved to make it happen, so all can know their role in supporting the outcomes. Allow more autonomy. We need to avoid the more bigger the organisation, the more the red tape. Allow senior managers to make decisions at scale without having to cascade up. Values again has come up. A leadership team that beyond the ICS is truly behind the vision. Briefings, patient involvement at every level of decision making. I'm just going to pick some more out. Experts by experience should be top of the list. Thank you. Demonstrate quickly and openly that contributions can have an impact and make a difference. And build trust with the community. So thank you for all of those comments again. At 152 so far, which is just brilliant. So next slide, please. So integrated care in the Black Country. We put together this video. You may recognise the person introducing it. And it's all about integrated care in the Black Country and what we're aiming to achieve. And whilst we're playing this video, if you've got any questions that you do want to ask of either Jonathan or myself, then now's the opportunity to pop them in the chat and we'll go through those as well at the end. So please do submit your questions in the chat. Well, over to the team behind the scenes who are going to play this video for you.
Hi, my name is Jonathan Fellows and I'd like to take a few minutes to tell you about the integrated care system we're building in the Black Country. In particular, I want to talk about what an integrated care system is, what it will do and why we need one. The Black Country has a population of nearly 1.3 million people and it covers the 4 boroughs of Dudley, Sandwell, Walsall and Wolverhampton. It was one of the birthplaces of the Industrial Revolution, with coal mining, iron foundries, glass manufacturing, brickworks and steel mills, all creating high levels of pollution. The first time this area was called the Black Country appears to have been almost 200 years ago, in the 1840s. It might have got the name because of the soot and the smoke from all those industries, or perhaps it was because of all the coal seams close to the surface. What is clear though is that although the heavy industries have now largely gone, their legacy lives on in terms of the impact on the health and the well-being of the Black Country population. Sadly, many people in the Black Country don't live as long as those in other parts of England. A lot also don't enjoy good health and face other challenges. There is a great deal of poverty and deprivation in the Black Country. Just under half of all the people in the Black Country live in some of the most deprived areas of England. There are also more people in the Black Country who don't have jobs, don't have qualifications compared to the rest of England, and children don't do as well in school as in other parts of the country. Healthy behaviours and lifestyles are also important when looking at people's health, as these lead to more people living with long-term conditions and ill health. The reason we need to alter how we're providing health and care to our population is so that we can work alongside our communities to start to change some of those outcomes. It won't be easy, but that mustn't stop us from doing everything possible to make a difference. The population of the Black Country is very diverse. Overall, around 30% are from Black, Asian or minority ethnic communities, although in Sandwell that's as high as 40% and in Wolverhampton it's 39%. Communities include people from Bangladesh, China, Gambia, India, Italy, Jamaica, Nigeria, Pakistan, Philippines, Poland, Somalia, Zimbabwe and Yemen. We need to make sure our healthcare services are easily accessible and available to all of them. The environment in which we're born, grow up, live, work and age in, as well as the decisions we make for ourselves and for our families, have a bigger impact on our health than healthcare alone. We know that differences in health outcomes and life expectancy, as well as opportunities for good education and job prospects, don't affect everyone equally. So a one-size-fits-all approach won't work. We need to work with each of our communities to help identify the specific problems to tackle, and we'll also need their help to come up with the best solutions. The COVID-19 pandemic has shown us how health and care services can work together better. All services played with GPs, councils, voluntary and community groups working together in local neighbourhoods to reduce isolation, tackle loneliness, support those most vulnerable, while hospitals work together to share resources, look after a lot of people suffering from COVID-19 and also ensure that people who are ill could still get the treatment they needed. But even with all of the great examples of our health and care systems working together and breaking down barriers, we know that for some of our communities, COVID-19 has led to inequalities increasing, not reducing. To carry on, we'll need more hospitals, more care homes, and a lot more health and care workers. Not only is this unaffordable, it also wouldn't be the right thing to do, as it wouldn't help people to live longer, nor help them to live in better health. We need to change. One of the most important things to realise is that health cannot be improved and health inequalities will not be reduced by the NHS acting alone. Although improving the quality and accessibility of health and care will play a part, there are many other factors such as income, education, employment, training, housing, the environment and crime that all have an impact. Only by working together to deal with all of these factors will we start to be able to make a difference. So our integrated care system is a partnership across health and care providers, local authorities, voluntary and community organisations, the police, fire services, housing, education, colleges, universities and large employers aimed at coordinating services better, improving the health and the lives of Black Country citizens and starting to tackle and reduce the inequalities that exist between the different communities across the Black Country. By working together with partners from our integrated care system, we want to improve outcomes when people need hospital care and treatment, improve the health of our Black Country population, remove the inequalities that we currently have in access to health and care, provide care that focuses on the person receiving it and makes the best use of their time, connect health and care services in a more joined up way so that we can make better use of the money we have, and play our part in improving education, training, employment and housing to give our communities better prospects. I said earlier, none of this will be easy, but I also said that mustn't stop us. By 2030, with more people living into old age, some of the things that will help us to know that we've succeeded will be if people are living longer and healthier lives, people are staying healthy in their own homes and communities, people are taking greater responsibility for their own health. When people need hospital care, they get the best care at the right time, and prospects for education, employment and housing are much better. However, there are also two other groups that it will be vital to have deeply involved if we're going to succeed. The first group are the communities we serve, who need to tell us the things that need to change and help us to find the right answers. And the second is all of the people that work in health and care. They have a vital role to play, as they will know what changes will make the most difference. They will know how to do things better, and we need to involve them. Most of the time, our people and our communities know what the solutions are, so we want to listen to them, work with them and support them so that together we can make the right things happen. This will be a new way of working, putting people and communities at the centre of the whole system. I hope you will all want to play a part to help make a difference and to deliver a healthier future for everybody in the Black Country. Thank you.
Thank you, and I hope that video really helps explain exactly what we're trying to achieve. Is there another slide after this? I can't remember. So next slide if there is one. Maybe there isn't a next slide. So we'll go. I think we'll start to close the session there. So first of all, a huge thank you to all of the comments, 166 of them. I'll pick up where we kind of left off before we play the video. Some comments about you said and we did, absolutely, and values-based approaches to recruitment. Some challenges in terms of top managers setting the ethical and organisational standards. Co-production. A couple of comments about the video, Jonathan. So I think people want to hear more from you. So will this video be available on YouTube? Yes, it will. And we'll make sure that we share the link out. A comment from Marie, and it's something I'm really passionate about, that we should always take note of frontline delivery workers. Never assume you know if you are not from a clinical background. It's frustrating when decisions are being made and the top level managers don't walk the floor. Find out, see, communicate, and too many assumptions are made. There is something about that decision making process, but I'm also really clear that we should give the people that know the services best the tools and the resources to make the decisions themselves, that we don't make decisions that are too detached from where services are delivered. Another plea to share the video link, which is great. Hi Jonathan and Mark, great to see you. How would you go about embedding social care needs within the health needs of the population in practice, taking into account the wider determinants of health amongst our very rich and diverse populations across the Black Country? Where do you feel this integration should start, e.g. primary care or within local communities? So my view is that it does start in those local communities, and quite often it does centre around the GP practice. What we're looking for is a kind of multidisciplinary approach to this, and where that works well, and I've seen it work well, it works fantastically. So, and that involves not only care, mental health workers, physical health workers, the GPs, it involves the voluntary sector, it involves social care, it can involve community groups, for example, and bringing all of those together. They are the people that know that area best. They are quite often the individuals that will know, the people that will know that individual well, or their family, or the circumstances in which they are living. So it absolutely should centre around primary care or local communities at that smaller population level, because that's where the most difference will be made. A superb comment from Alan about sharing the video link through emails. The levelling up agenda needs to include VCS and faith-based communities to cover our core costs. It is essential fair costs for care and is enshrined into the ICE. Have you mentioned local councils as partners? Yes, we have. So local councils will have a place around the Integrated Care Board, but the other element of our system, which is the Integrated Care Partnership, will absolutely be driven by our local councils. And we're talking to them very closely because we recognise that local councils, and through the elected members in local councils, that we can get really strong feedback on communities and make decisions that, you know, are as close as possible to where people live and are linked into those communities that they represent. The organisation must become a leading trust in the field of equality, diversion and inclusion. Thank you. GPs have a large role within the CCG and much less in the CCG, yet ICS, yet provide most face-to-face services. Is this a concern? It is, and it's something I'm really mindful of, and that's why we've made sure that in setting up the Integrated Care Board, that the number of places that the local trusts have, the number of places the local authority have, that primary care, that voice is equal. But in each of our places as we develop for the year, we need to make sure that the voice of GPs is absolutely strong and centred around those place-based partnerships. Just looking. Positive way to try and explain the ICS and the possible direction of travel for the Black Country. It is such a complex landscape, and we have so many partners that we need to work with. So thank you for all of those comments. We do collate these and share them, so they are truly appreciated. Themes that have come out today, absolutely want us to empower you as communities in terms of how we make decisions. You recognise and have told us, and we absolutely recognise that one size won't work for everything. And we need to make sure that I certainly work on the basis of, you know, what is the right population for the best outcomes. Solutions are there. We just need to work with you. And absolutely, how do we make sure that we stay connected to those communities, be it through experts by experience, be it through trusted community groups. So a huge thank you for everything that you've contributed today. I think we will run more of these sessions as we get into it and maybe pick some particular topic areas out, like inequalities, for example, health inequalities, some of the work we're doing around that. So if you've got any thoughts or suggestions on topic areas you would like us to cover, please pop them in the chat. We'd really welcome them, and we can start to develop a programme throughout the year. But again, thank you for everybody's comments today. Thank you for taking the time to watch, and thank you for taking the time to tell us what you'd like to see. Thank you, everybody.